Welcome to the Summit Lunch and Learn on the therapeutic management of COVID-19. So today's session is not a CE course, so this is not offered to provide continuing education credit with any of the accredited organizations. It's just a supplemental learning opportunity, so you won't get a continuing education certificate for completion of this, just FYI. However, this is the only time I will do a shameless plug. If you are interested in getting continuing education, I do have a longer version of this course available through Summit, where I go more in depth. It's a 2-hour CE course. I go a little bit more in depth into therapy's role in management of the COVID-19 patient. So anyway, there's your one little shameless plug. This is my first lunch and learn that I've done. I've done several Summit courses, but this is my first lunch and learn. I will do my best to answer questions. I'll be paying attention to the Q&A throughout the course, so feel free to ask questions through the Q&A as those questions come up, and I'll do my best to answer them. I try to do my best to answer them as they come up. So just FYI on that. So therapeutic management of the COVID-19 patient. Want to do a quick review. How did we get here? So you have the 2019 novel coronavirus, or 2019 nCoV, novel meaning new. So this was a new coronavirus identified in 2019. It was first reported in Wuhan, China, December 31st, 2019. Now, I'm going to, as I go through this, I'll be going through what we actually have evidence for, what is documented. So, this was when it was first reported. 2 weeks later, January 13th, we have the first case outside of China, and that was reported in Thailand. And a week after that, we have the first documented or verified evidence of human-to-human transmission that was verified by the World Health Organization. And 30 days after it was first documented, we have 7,800 cases in 18 countries worldwide. At that point, it was declared a public health emergency of international concern, a global pandemic. And so that's how we got here. It's important to understand what the COVID-19 virus is. There's a picture of it. You see the little spiky protrusions, whoever first Okay, I've already got the first question. When does sense of smell return? We don't know. Everybody's a little bit different. I'll tell you anecdotally, I'd have a friend who was diagnosed with COVID-19. 3 months after his diagnosis, he was still having taste issues, and he's a big foodie. So I don't think we have an exact number on that, but I'm going anecdotally, 3 months with the sense of taste, and a friend of mine was still reporting. Actually, I have another friend who said that she was, I think, 3 or 4 months and still not having her full sense of taste. I mentioned taste in relation to smell because those are the two chemical senses, but I don't think there's an exact answer on that. But how did we get, so this is the COVID-19 virus, corona meaning crown. Whoever first saw it said that looks like a crown. That picture is an actual picture of the coronavirus, blown up significantly. It's from an electron microscope. This was from the CDC, National Institutes of Health, so it's publicly available. So you probably see a lot of people using that particular picture. Those little spiky protrusions become the problem because those like to attach themselves to healthy tissue lined with mucous membranes, so frequently in the lungs. It's important to understand what the virus does, and in order to understand that, you've got to understand cytokines and the cytokine storm. So cytokines are an important thing in moderation. Cytokines help to regulate immunity and inflammation. That's in moderation. However, like anything, got a question on neuropathy. I will actually come to that. The short answer is yes, there are documented cases where the COVID virus can cause neuropathy as it attacks the nervous system. So in short, yes, it can. But again, every single person is different with the various symptoms that they're experiencing. But when we have unregulated cytokines, you're seeing, that's what you see in several autoimmune type diseases, lupus, arthritis, and yes, diabetes. Me personally, I like to describe the COVID-19 virus as diabetes on steroids and meth. So, I will frequently pose the question when I'm presenting, whether it's to students or to therapists. If I'm talking about diabetes, what organ systems, what body systems does diabetes affect? Well, the correct answer is all of them. When you look at a cellular level, you get into the pathophys. What diabetes is causing is inflammation. Whether it's when you do a root cause analysis on macular degeneration in diabetes, what you're finding is inflammation. When you're looking at neuropathy and diabetes, you're finding inflammation, and we see that same thing in with the cytokine storm. That's caused by the COVID-19 virus. When we look at more severe cases in the COVID-19, with COVID-19, what we see is presented here. You can see liver failure, renal failure, heart failure, respiratory failure, so system-wide failure. We see blood clots when you combine that with respiratory failure and prolonged immobility. You see even a bigger risk for blood clots. We see hypoxia again as it relates to respiratory failure. One of the big things to be aware of is silent hypoxia. Most cases that I have seen, there has been at least some form of silent hypoxia, so different levels of severity. When I'm talking about silent hypoxia, we're talking about people that are up, walking around, apparently feeling fine, no visible signs of shortness of breath, yet they could be satting all the way down into the 70s. That's what I've seen. Now, I've seen documented cases of patients that were desatting all the way down into the 50s. And again, they don't feel short of breath, and they're not visibly short of breath. So, you could have a significant problem there. This is one of the things that first kind of alarmed me when it came to COVID-19. COVID-19 for me was kind of a passion project, really. When we first started learning about it, I got very interested and really started doing a lot of research. On a personal level, my dad has a lot of respiratory problems. He's been intubated twice, and I knew this could really be a death sentence for him, and so I really wanted to learn about it. When I started looking into it, my initial thought was this is something that's really just going to affect older people. In May of last year, there was an article that was published, and the current slide comes from that slide. It was the first thing that really made me raise an eyebrow about COVID-19. Personally, I've treated, I'm in the home health setting. I've treated, the last I counted, I don't know, 30 some odd patients with COVID-19. I've done over 100 one-on-one visits with patients that were recovering from COVID-19. So I have a decent number of patients to draw from with my experience. Fortunately, I've never seen anything as severe as this, but I've only had one patient under the age of 50 as a patient. But this was reported from New York. A physician reported this in the New England Journal of Medicine. I believe it was May of last year. And what you had was it was a case study done on 5 different adults, all below the age of 50 with major vessel occlusion strokes. Now, you have one person under 50, that's the statistic, because it is so rare that you have an adult under 50 having a large vessel occlusion stroke. And then this was a situation with 5. All 5 had COVID-19. So you see on the left, these were the clinical presentations of the stroke. On the right were the clinical presentations of COVID-19. It was 4 males, ages 37 to 49, 1 female, age 33. The one that I want to highlight here was the female, age 33, was the one who had fever. And she was actually staying home, knowing, she thought, okay, I have a little cold here, but she was staying home specifically to avoid going to the hospital and exposing herself to COVID-19. So she really didn't even know how she got it. But that was her clinical presentation of COVID-19. So why do we see this difference with young adults? We don't really know. It's just speculation. Using the woman, the 33-year-old female, as an example, she was staying away from the hospital even though she had some symptoms. I think, I don't know what setting everybody here is from. I'm in home health, where it's primarily an older adult population, and my experience has been that older adults are more likely to seek out healthcare, and they're likely to do it sooner than younger adults. And the speculation is that that's kind of what's going on with COVID-19, why we see that difference. Older adults having some respiratory issues, they head to the hospital, they get treatment, they initiate treatment. Younger adults don't, so the virus has a longer time to run its course. That's just speculation, but that's the best that we have still at this point. We see ICU acquired weakness from prolonged immobility. We see vascular circulatory problems, both resulting from inflammation. There's a increased risk for clots. We certainly, when you see prolonged immobility, you're going to see a further risk for clots. We see the breathing difficulty, pneumonia, probably the most severe thing. With the abnormal blood oxygen exchange, we're going to see hypoxia and silent hypoxia. All of these, again, we're looking at that cytokine storm. I apologize. I think in my longer, and I thought I had a slide here on the neuropathy. That's probably in the longer version of this course that I do have. But again, the short answer is yes, we do see incidents of neuropathy. Pretty much, I think, to the individual that was asking about neuropathy, what I would say is if we see it in diabetes, more than likely, you can see it in COVID-19. That would be my best rule of thumb. When you start looking at the anything that diabetes is causing, we see renal failure. In some incidents, you can see liver failure. You can see visual problems. any of those things have been any of those things that we've seen with diabetes have been documented as well with COVID-19. We see cardiac effects. Tachycardia, cardiac arrest. The cardiac arrest is due to oxygen not reaching the heart. So we have a lack of oxygen reaching the heart. We don't technically call that a myocardial infarction because in order to be an infarction, there would need to be an actual blockage. Stress-induced cardiomyopathy. I kind of, when I'm talking to patients, what I tell patients is you need to think, your heart is a muscle, the most important muscle in the human body. And when we're talking about stress-induced cardiomyopathy, think of a muscle getting a cramp and imagine your heart getting a cramp because it's worked out so hard. Now, that's what stress-induced cardiomyopathy more or less than when I'm explaining to a patient. Again, that's how I explain it. One of my favorite things to say is Takotsubo cardiomyopathy. That's one of the names for stress-induced cardiomyopathy, but it's also known commonly as broken heart syndrome. So can you die from a broken heart? Yes, you can. What's happening here? Well, the heart rate is increasing, again, as a result of stress. And that's going to alter that's going to create a less effective blood oxygen exchange. Here we're seeing the heart rate increase as a result of a poor blood oxygen exchange. So the heart rate is increasing to compensate for that decreased oxygenization that's going on throughout the body that's coming from COVID-19. All of this, if you look at it on a cellular level, what we're seeing is widespread inflammation. One of the big things that I think can get neglected are the mental health effects, both with our patients and also with us. I want to do a quick pulse check. I'm going to send this out right now. How many of you, I'm going to just be blunt, how many of you are just tired of dealing with hearing about like you get home, the last thing you want to do is deal with COVID-19, questions, discussions. Obviously people are logged on here because you're interested in learning, but how many of you are just exhausted from this? So I'm going to send this. I'm just kind of curious within the audience how many people are feeling some of these mental health effects. Again, I work with a largely older adult population in home health where we commonly see social isolation as a problem. Social isolation is a problem before COVID. That's going to increase anxiety, stress, depression, and incidents of suicide. At my home health agency, I've been the alternate administrator for going on 3 years now. And in my first 2 years, I don't think we had one incidence of suicide. And in the last year, we've had 3 suicides. Now, I didn't get into looking at I wasn't reading any suicide notes, but, it's hard not to link these two. So I'm looking here at the pulse check. I got 270 people are feeling some sort of mental health effects, some exhaustion from this. So 273 with the thumbs up that are feeling it, and we've got 14 that aren't. So for you 14 that aren't, man, more power to you. I'm happy that you're not all feeling it, but I think the majority of us are feeling this to some level or another. So thank you for checking in. I'll end that. I'll have another pulse check a little bit later. So what is our role? Well, the very first thing, we've got to take care of ourselves. From a mental health aspect, I'm just going to let you know, for me personally, my exercise routine has probably increased by 50% just to deal with the stress on my own. Keep yourself healthy mentally, keep yourself healthy physically. Make sure you're wearing the proper PPE. I know that's changed quite a bit. You got to take care of yourself before you can take care of others. So, that's just a little, I'm just offering that to you all. Be aware of that as well with your patients. Human to human interaction is really important. Yes, we get something from a phone call, but we don't get eye contact. We don't get touch. For our patients, our older patients, teach them how to do a FaceTime call. For the OTs on the call, I'm sure there is some sort of cognitive sequencing that's going to go on. I'm sure you can figure out a creative way to integrate setting up a FaceTime call, teaching a patient, working with a patient on how to use a device to do a FaceTime call where they can at least get eye contact with family members. That might be the best social interaction they're going to get. And one of the things that we know is while phone calls can be nice, that does not stimulate the production of oxytocin. You actually need physical touch and eye contact in order to get that oxytocin being produced. Question about PPE. What PPE am I wearing in the home? Good question. First and foremost, it is N95 mask, face shield, hair bonnet, booties, gown. And I'm going to go off on a limb here since I am in home health. I wear a double pair of gloves. Now, that is not the recommendation of the CDC. In fact, the CDC does not recommend gloves. When you look at the CDC and their rationale, it's not going to aid in preventing viral transmission. However, that is a really interesting. I'm going to come back to that, Subrow, post-COVID syndrome, like post-polio. I'll just tell you, I think that's completely possible. There's debates over post-polio, but we obviously don't. You got me smiling. You got me my intellectual wheels turning here. I think it's entirely possible and probably likely that we'll see that. We don't know the long-term effects of COVID at this point. Even for someone who's not having a stroke, we don't know the long-term effects. I mean, it's like 9/11 and 9/11 lung. I mentioned my father. My father has the symptoms of 9/11 lung, which I never even thought was a thing. I dismissed it. But, the cases were, people were developing that, 10 and 15 years after the fact. And there is zero history of respiratory problems in my family. And my dad has all of the symptoms. He was there on 9/11. But I think it's entirely possible we'll see like a post-COVID, long-term effects from COVID. Back to the PPE with the gloves. So the CDC does not recommend a double layer of gloves. But the reason why they say it is because of viral transmission. It's not aiding it. In fact, they're concerned that wearing 2 layers of gloves may give a false sense of security. For those of us that are in home health, CDC does not write rules and guidance for us. They write rules and guidance for people in a facility. If I was in a facility, I would not wear 2 layers of gloves. I can walk out of a patient room, remove my gown, pop off my layer of gloves, and sanitize my hands right then and there. And I probably don't have to worry about sanitizing my equipment. If I do, I can grab another set of gloves right there and then move, whatever equipment I might need to sanitize. In the home health area, anything we bring into the home, we have to sanitize after leaving the home, but before we get to our vehicles, because the last thing we need to be doing is bringing something dirty into our cars. So when removing the PPE, your out, for me, it's an outer layer of gloves is dirty. I've got to remove my gown, my hair bonnet, my shoe covers, all of that, remove my outer layer of gloves in order to clean my equipment. Otherwise, I'm grabbing hold of my equipment with a dirty set of gloves because that has been exposed to the patient. Been wearing a Tyvek suit when available for home health, feel very safe. We're not using those is what I can say. The only thing we use the Tyvek suits for actually, I'm going to do a quick pulse check right here, just out of curiosity. How many of you are in home health? So I'm just curious how many home health people we have on the call. But Tyvek suits, the only time I've ever used a Tyvek suit is when a patient has bed bugs. So yes, gross. That is something that in home health we have to deal with. But I haven't done any specific research. I would feel very, very safe wearing one. Anyway, so I was just curious there. So seems like most of the people on the call here are not in home health. We do have, maybe about 25%, but most of the people are not in home health. So Lisa, good question. I wear the N95 mask, gloves, and a face shield with every patient. I don't wear the gown or hair and shoe coverings with every patient. The gown and all of that is reserved for COVID patients. All right. Thank you for checking in. Monitoring vital signs prior to exercise, blood pressure, temperature, important to check. Respirations, oxygen, and heart rate before, during, and after. I check those throughout my visit. In fact, if you were to look at my documentation, you would think all that I was doing was documenting vital signs. I am checking those a lot. Because I'm trying to document the patient's response to exercise. Yes, we do. Subrao has the question: do we do a COVID PPE competency on therapists? Yes, we do. We do that. I walk them through. In fact, we do that with both our in-house team and our contractors. We train them as well, because it's beyond just us. We have multiple people that are taking care of these patients. So yes, they are in service and competency on donning and doffing of the PPE. When we're looking at response to exercise, I recommend the use of Carvonin. Now, there is a limitation to the Carvonin. That limitation is patients that are on beta blockers and or have a pacemaker. Carvonin is not going to work. But Carvonin, if you remember, 220 minus your age, and then that's going to give you the predicted max heart rate. You multiply by 80%. We don't want someone to exceed 80% of their predicted max heart rate. That is a safe exercise zone. So if you have an 80-year-old patient, you do pre-exercise assessment of vitals, and that person the heart rate is running 105. Well, you've only got 7 beats to work with. That person is working really hard just to exist, just to be sitting there, on room air or oxygen. So that's how I use the Carvonin formula. Let me check these questions. Okay, got a comment from Shannon. Had a patient that was I want to share that I had a patient that was COVID. He was a long haul trucker, 8 weeks tachycardia, every cardiac test imaginable, always normal. O2 sats above 96. This is very interesting. Sometimes the measuring tools we use, that is true. Patient could not walk 25 feet without discomfort. So yeah, obviously we're going to listen to our patients. One of the best pieces of advice I was ever given: if you listen to your patients, they'll tell you what's wrong. if you listen to them long enough, they'll tell you how to fix it. Karen has a question. Do I treat post-COVID patients only? They are not active while you're treating them. No, we treat both. It just depends on when they're being discharged from the hospital. They are trying to get them out as fast as possible. If they're stable, they're sending them home. So we've got plenty that are still active. Can you speak more to the monitoring of O2 and indications to limit or continue activity? Thomas, great question. So my favorite, your best answer from school, it depends. Carvonin is not going to be reliable again on somebody who is not who has beta blockers or a pacemaker. So monitoring oxygen and heart rate are going to be really important. Not every single patient is going to have an elevated heart rate, as someone had just previously pointed out. Very, very true. Need to monitor the oxygen throughout as well. Now, I don't know what state you're in, Thomas. You need to check your state practice X. What's important to remember is oxygen is considered a medication. In Texas, where I'm located, as a physical therapist, I am allowed by Practice Act to do medication management as those medications affect physical therapy, their physical therapy performance. Oxygen is included with that. So I may have a patient that goes home on a flow rate of 2 liters, of 2 liters of O2. That oxygen, that flow rate can be limiting what they're able to do. I might, guidelines are if it drops below 90%, we need to stop exercise. That's Practice Act guidelines. So what I do is I make a phone call to the physician and say, hey, can I get a PRN order? And I'm allowed to do this again as a PT in Texas. OTs can't do this. Speech therapists can't do this. Assistants cannot do this. But I can get the order that allows me to make an adjustment to the O2 rate to keep the oxygen above whatever, the pulse oximetry above whatever level the physician is comfortable with. And we've had physicians that say as long as it's over 85%, you can keep exercising. So adjust the oxygen to keep it over 85% during physical therapy sessions. So hopefully that answers your question, Thomas. If it doesn't, if you need me to speak more, let me know. When do you start the case? Do the patient has a prior test? When the patients that we get, we know where they're at. We'll find out, okay, you tested positive last week, you're home from the hospital, you were never hospitalized, but they're sending in home health because of whatever. Not all of our COVID patients were in the hospital, but the vast majority were. So it really just depends on when we get them. And I go through the full assessment to determine what's going to be applicable to that patient. How frequently so our staff does not get tested unless they have a known exposure or they're presenting with symptoms. Fever, fever is kind of the telltale one, but it would need to be fever. There needs to be some sort of symptom, a reason to have them tested. So that was from Mercedes. RPE should be a better indicator of patient condition. So here's the issue with RPE. Can it potentially be reliable? Yes, but research, there's a possibility. If I have a patient if I have a patient that's on beta blockers, I may use that in relation to that patient and their perceived exertion. However, because we know about the silent hypoxia, that's patients that think they're doing just fine. So the Borg RPE is really not effective. It's not reliable because you could have plenty of patients that think they're doing just fine, but they're really not. One specific example that I had was one of my early patients. I arrived at the home. He was up walking around. He felt fine. He had an oxygen concentrator. He was not using the oxygen. I started checking, had him sit down. Oxygen saturations were 78. Heart rate was normal, but his oxygen saturation was 78. So I actually had to have him sit down, get the oxygen on, and educate him day one about the importance of his pulse oximetry. Then as we got his oxygen saturation stable, what was happening is his heart rate was starting to compensate. So we saw that elevated heart rate as a result. So that was Jennifer's question about modified. So modified Borg or Borg, they're not as reliable, again, because of that silent hypoxia where patients think they're doing just fine. Zahra, have I seen research on O2 sat versus temperature as a screening for COVID infection? The answer is no. That's an interesting question. When do you discontinue? I will research that just as a follow-up. That is an interesting question, but I have not seen any research on it. And such a big part of this is every patient presents a little bit differently. Sorry, I just lost one. When do we discontinue PPE after positive tests? Right now, we're following the CDC guidelines, which is 10 days post-diagnosis, and we want them 24 hours without a temperature. Have you seen a significant change in patient demographic, non-COVID versus COVID diagnosis in the home health setting? Prior to COVID, there was a shift in drive to DC home versus SNF. That does kind of makes sense, but the vast majority that we're in demographic non-COVID versus, okay, sorry, I understand the question now. What probably the biggest shift in Texas when I don't know what state you're writing in from. One of the biggest shifts that happened, they canceled so many elective surgeries, so we weren't seeing total joint replacements because all elective surgeries were being canceled. So I would say yes, we did see that kind of a shift. A larger percentage of our population, it was like it replaced, like the COVID patients all replaced what we would normally see with our orthopedic patients. Yes, home health referrals I have felt have been very appropriate. And this is a great question. Oh, Lolita, I love your question. Do I feel that that home health, that the patients would be more appropriate for outpatient because they're independent with mobility? That is such a good question because that goes right back to the silent hypoxia. You could have some of these patients that look fine when they're getting around the house. Where does our skill come in? Our skill comes in helping those patients modify their exercise, modify their normal everyday activities of daily living. Teaching them how to monitor their pulse oximetry, giving them those guidelines, and increasing their activity level gradually and safely. On top of that, there was a relaxation in homebound documentation requirements. If you have a patient that is recovering from or at a risk for COVID-19 and the patient has a skilled need, then you can consider that patient homebound. So, those of us that do home health, I think most of us are pretty much generalists. And I think a lot of us have forgotten our cardiopulmonary training, or maybe if we haven't forgotten it, it's just not something we've used on an everyday basis. So, yes, there is a huge skill. And I think that, for the most part, they are appropriate to be at home versus out in the community where they're, at risk for, exceeding safe levels of activity. I need to know, like I have the 2-minute step test set up here, the slide here, and I have the 6-minute walk test here. What can the person perform? What can they do safely? What are their vital sign parameters? Maybe the patient, again, feels fine. They've got a Borg of, 1 or 2, but, I've got an 80-year-old who's satting at 87% and her heart rate is 116, but she feels fine. My skill is telling that patient, okay, look, you need to stop. This is when you need to stop. Here's what you can do. Here's your parameters where you can exercise. And, this is what we're going to do right now. Here's your homework. And this is what we need to, what we'll be looking for as we move forward. So a 6-minute walk test, highly functional. I already, there was the slide on the 2-minute step test. There's the 30-second chair to stand. These are just a handful of some outcome measures that can be considered. Let me jump back over to your questions. I got quite a few here. Sorry. Have I come across any research that pertains to when it is safe to start PT, OT with COVID-19? Yes, we need to be getting in there early, Kelly. Early intervention. You might be going in doing, proning the patient. You could have a patient proned where you're having to go in and do percussions, doing some postural drainage. I believe Julie Barnett, who's another Summit instructor, has a great course on that's available. If you're it's available, period, but there's an all access course on postural drainage and positioning. Julie's a great teacher. She was one of my instructors when I was in PT school, so I'll do a plug for her. But yes, there is definitely skill that can be done very, very early on and needs to get started depending on your patient's activity level. Current clinic, hospital base with acute, wow, you do everything, inpatient, home health, and outpatient. More post-COVID and outpatient for musculoskeletal pain. Can you speak to musculoskeletal and neuromuscular pain problems in post-COVID? Any recommendation for overarching outpatient who have transitioned from home health? I haven't seen a ton on pain specifically. And I think part of that is because so many of these patients are just so acutely sick, pain almost becomes a secondary thing. So as far as what modalities to be using, I'm going to shoot from the hip here and tell you, I'm going to shoot from the hip here and just kind of give you my gut feeling on it. And since this isn't for continuing education, I can do that. But shooting from the hip, I personally go back to, pain is usually a result of something going on, some sort of movement dysfunction, whether it's prolonged immobility or the person, prolonged immobility and now the person is weak in a certain area, so they're moving incorrectly. So I'm going to be focusing on getting that person moving correctly. Specific modalities, I haven't come across anything, but what I would say is ask your patient, you may have to do some trial and error to figure out what modalities are working for your patients. Me personally, depending on what state you're in, one of my favorite pain modalities has become dry needling, but I know that not every therapist can do that and not every therapist is trained. I have read somewhere that sense of smell seems to be more prevalent than fever as an indicator. Anecdotally, I think that's pretty correct from two people specifically that I know that had it. It wasn't their smell, it was their taste. But again, those two senses are so closely linked. I can't say if one is more than the other. I know on our check, I have to check in when I go to the office every single day. They check my fever, and sense of smell, taste is one of the questions that I'm screened for. But I don't know, as far as the reliability, which one is more reliable. You almost have to look for the cluster of symptoms. Seeing more significant increases in cognitive deficits and motor planning with COVID-19. I can't say that I have, that I've seen a significant change beyond, like, as far as COVID. One of the things that does happen quite a lot, you have a patient with advanced dementia or even early dementia goes into the hospital. The dementia seems to advance just while they're in the hospital. Now, whether or not, we certainly have, there's ICDU psychosis. So whether, if the person was intubated in the ICU, that is a known thing. But as far as people with COVID and a comorbidity of dementia, I don't know that you could necessarily tie the COVID-19 versus a general hospitalization. I wouldn't necessarily blame it on the COVID specifically. Do you use a specific brand? That's a good. So I have one. I don't remember even what brand it is that I carry with. Actually, I have two of them that I keep with me because I'm in home health and I have a tendency to forget them from time to time at a patient's house. I forget what brand our company uses, so it's whatever was provided by the company. But whatever the patient has in their home, I'm perfectly fine with. And if they don't have one in the home, I am recommending they purchase one that day. And hey, this is the least expensive one. This is what I go with. In acute care, what are the best parameters with regards to high flow oxygen and mobilizing a patient? We have a patient on 100%. Wow. Holy cow. What is the hard no parameters? Wow. Again, you got to look at what the patient's, you got to look at how the patient is responding. What is the patient's, what are their vital signs? If your facility has a specific hard no, I would certainly be going with that, but I don't know of a specific, hard no, hard line stop that we would do as a result of somebody's on high flow oxygen, or you can. If the person's awake, you can go in and mobilize someone who's on a vent. You can go in and do passive range of motion on somebody who's on a vent. So it really depends on the person's vital signs. That's what I would be basing it off of. Will you be talking about exercise ideas on things to work on with COVID patients? Also, how to justify therapy to our insurance? Great. Okay. The three previous slides and this one that I kind of sped through, I'm trying to answer questions at the same time, but outcome measures: 2 minute, 6 minute walk, 2 minute step test, 6 minute walk test, 30-second chair to stand. Guess what? Those are treatments just as they are outcome measures. I may set a goal here. I might set a goal for a person to be able to complete a 2 minute step test, or complete the 6 minute walk test. Or let's do the 6 minute walk test with the age adjusted normative value, or complete the 6 minute walk test with an age adjusted normative value and keeping, the heart rate under 112 beats per minute. For like the example that I have right here. So those are, those are just a couple of things. For me personally, what I'm doing, and this is outpatient, home health, SNF, acute, whatever setting you're in, we do one exercise and then I'm checking the heart rate and oxygen saturations. Oh, you've dropped below your baseline, below, what we want you at. All right, how long does it take you to recover? How quickly are you recovering? Do you need oxygen to recover? What were you reporting? What was the patient reporting? Those are all of the things that I'm looking at that are justifying my skill, because your skill isn't throwing in a bunch of exercises to the patient. Your skill is we're doing these exercises and we're adjusting them and modifying them and assessing the patient's response to exercise. That's your skill. It's that skilled assessment that you need to be doing. This next slide kind of shows the same thing, utilization of the vital signs and specialized tests as things that we can monitor in order to watch that return to baseline. So that was Anjani. Let me keep moving up. Sorry, trying to get these. How low do you allow oxygen to drop? That's going to depend on the physician. If the physician has not given me a specific guideline, then I'm going back to our Practice Act, which is going to state we want to keep it above 90%. What is your average treatment plan duration? In home health, I will typically start off, around 6 visits twice a week for 3 weeks, or 3 times a week for 2 weeks, depending on the patient, where they're at. And then it just depends. I've had probably 60% of them, 70% of them, they're good after the 6 visits. They're stable. They're able to monitor their themselves closely. They're feeling comfortable with everything. They've met goals. But that's going to depend on that, that individual patient. Some of them, they're still not safe. Their vital signs are still, I'm going to use, technical word, but still wonky, not doing what they should be doing. So it's treatment plan duration. What are you providing as skilled for your COVID active patients that have been sent home from the hospital within 10 days and they still feel terrible? Again, I think I kind of touched on that on a couple of previous slides, but it's going to be patient specific. I'm looking at things that are functional. A number of our patients, I would say a majority of the patients are physically able to get up. They might be able to dress themselves. They might be able to do the transfers. However, it's the vital signs. That's the skill. It's how the body is responding physiologically to the exercise, to the functional, those functional movements. And we take it a day at a time. I had one that I just saw on Friday, brand new one, walking from the chair to the bed less than 25 feet, 4 liters of oxygen, baseline saturations 92% on 4 liters, and dropped to 81 just trying to walk to the bedroom. That one's not going to be able to do a whole lot. And it's going to, it might be something as simple as doing some, starting off with ankle pumps and heel slides, and then gradually moving that patient to standing, monitoring what that patient does in standing, attempting a 2-minute step test, perhaps while monitoring vital signs. If the vital signs are dropping, then you stop the test. But those are a lot of what we're working towards. Contraindications to proning. As far as standard contraindications, I can't think of any right off the top of my head. That's a great question. I would have to go back. I don't want to give you incorrect information. I would have to go back and research it. It's not something I do a lot of. Now, you have to be cautious with somebody who's over 50. They're going to be more prone, no pun intended, to stenosis, which means they may not like being prone. So you're going to have to make some adjustments on those, in the hospital with that table to make sure they're comfortable and you're not, causing pain. But again, I mean, if you're looking at pain versus trying to get oxygens working, well, any research to show contraindication to postural drainage for fear of mobilizing clots? Melissa, it's a good question, but I think the risk of immobility and not moving at all is a greater risk for clots. Is there a risk for mobilizing a clot? Sure. That's where you need to be looking at, what meds are your patients taking? What kind of blood thinners? What are they using for anticoagulant? I would definitely want to be aware of that. And always be in consultation with the physicians. But I would again recommend, listening to Julie's course, because she goes very specific into that. Working with any home patients for POTS post-COVID. Any specific limitation? I'm not sure. POTS. The only POTS I'm not sure what POTS is, so I can't really answer that question as far as limitation. I use kinesio tape for pain, e-stim. Sarah, if the patients feel better, that's probably the best. That's the best thing that I think you can do is if your patients are responding, then that's the most important thing. There's no contraindications to either one of those other than the normal contraindications that you would have for both e-stim and kinesio tape. I personally am not trained in kinesio taping, but when you look at e-stim, your normal contraindications, active tumors, somebody that has a lack of sensation, those, your normal contraindications. What would be parameters for a 35-year-old female mother of 3, long haul COVID, 2 months diagnosis, COVID pneumonia since onset, standard pulse ox 95, heart rate goes up to 158, just walking around negotiating 4 steps? Is that the max heart you want her to be? I got to do some math here real quick for you, but you're going to take, in order to figure this out, you're going to go 220 minus the age, which is 35, so 185 times 80%, so 148 would be 80% of the predicted max heart rate. So you really want to keep her below 148. And remember, that's 80%. So, she's, of the predicted max. Don't know what other comorbidities she has, but you want to keep that. You want to keep her exercising below 148. Talk more about silent hypoxia. If they are acute, ICU, how often? They often have high 80s heart rate, respiratory rate, and BP are within normal limits. So silent hypoxia is defined as what it's defined as is oxygen that's going below quote unquote normal, which is anything below 90% with no visible signs or reports of shortness of breath. High 80s, depending on where in the 80s, it's going to limit what you can do exercise wise. But again, you need to speak with the physician to find out what parameters the physician is comfortable with that patient operating in. Some of the documented cases are situations where someone walks into the hospital, is talking to the physician like I'm talking to you all, with oxygen saturations in the 50s. I mean, you're getting very, very dangerous there. You're getting very dangerous way before there. I've had one case, where that person went to the hospital. By the time the person got to the hospital, oxygen saturation was 52. So now that person was actually short of breath. But if that person had not been short of breath, that's where we're talking about the silent hypoxia. They're not showing outward signs of it. I hope that helps. Hang on, where are we? Oh man, I'm trying to keep up with all of these. Do you walk COVID patients outside the home with PPE? Yes, I do. Not always. It depends on where they are. I want the patient wearing a mask, but it'll depend on where that patient is. But if I need to complete something like a 6-minute walk test and the weather's nice, then if the patient's up for it, I'll take the patient outside. As long as they're willing to do it. Not taking them around a bunch of other people, but. Are you teaching proning on patients who have DC'd home from the ICU? No, I am not. I have not proned anybody in the home health setting. That really would be something to be done very acutely, but I have not done that. Breathing techniques. Really, it's been the pursed lip breathing, just like we do with the COPD patients. Also, use of the incentive inspirometer, we've done quite a bit. Do you have a preference? Active cycle breathing, diaphragmatic, I'm big on diaphragmatic and pursed lip. I can't say I have a strong preference over one over the other, but those are the two that I generally do with this population. So that's one that I've done. Let me see here. Any concerns with dry needling and COVID due to the stress response and immune already occurring, or bringing infection near the bone? It's a good question. Honestly, I don't know. But what I would say in response is, if it's something that you're concerned about, then find an alternative. I'm just, use an alternative if you're looking at something for pain modalities. Being in the home, I can't say. I mean, I've done dry needling on a bunch of patients in the home health setting. I mean, I've more done it on people that are asking me to do it, people that know that I'm trained in it. The reason I got trained in it is a bunch of people from my company all got trained in it back in November of 19, because we were planning on introducing that as a, non-narcotic pain intervention. Well, then COVID hit. So that all kind of went by the wayside. As far as infection, the risks of infection with dry needling are extremely small to begin with. But as far as comfort level, I'm going to go back. If it's not something that you're comfortable with, I certainly would not advocate for it. You got to be comfortable doing it. COVID patients, intercostal muscle strengthening. Marissa, no, I haven't, but I've also not looked for it. That's an interesting question. I have not looked for it. I think going along with, the deep breathing type exercises, the intercostals are going to, hopefully get stronger, but I have not researched that specifically. PDGM and COVID combined effect on home health visit utilization. In general, you're going to see an increase of visit utilization. The big thing is making sure your OASIS materials are all documented correctly from the very beginning. Okay, I said I would only do the one shameless plug. I do also have a course on OASIS coding. How to code your MOO items. That's going to be the key. But your actual visit utilization is probably going to go up a little bit. But again, we're averaging around, I would say 60 to 70%, off the top of my head, 60 to 70% of our patients were good after 6 visits. So we're not seeing super high utilization trend. Any breathing exercises? Yes, I think I answered that on a previous slide. Is the home health agency providing vaccinations for the staff? No, our agency does not vaccinate. Vaccinations. Okay, well, I've got the slide right up here. So let me touch on this, this very last slide that I had, and then I'll go back to the questions. So we currently do have the 3 vaccinations now. Well, 2 vaccinations, and 1 is about to become available. So Moderna and Pfizer. Moderna is about 95% effective, and Pfizer is 96% effective. The way they work is they're basically triggering the body to produce the antibodies. They're not, it's not a virus activity. It's actually introducing a protein to stimulate the production of this particular vaccination. I'll do a pulse check. How many of you have been able to receive your vaccination that want it? If you don't want it, just don't answer the question. But there's obviously been some issues, with it being rolled out, with it being out there. We know about some mutations. The UK strain, there's a South African strain, there's a Brazilian strain. Now, both Moderna and Pfizer they believe those are effective against the 3 mutations. Johnson & Johnson, when they published, 66% effective, period. So it's a more traditional vaccine, but it was not as good as they were really hoping. There is a probability that there's a good portion of the population that has a natural immunity. But then here's my favorite part here from Science Daily. And from Science Daily, you could Google this and find it, but it was a study out of the University of North Carolina. Chocolate, green tea, and grape products. So there is an anti-inflammatory, antioxidant compound that binds with the protease enzyme that is present in the COVID-19 virus. That COVID-19 or that protease enzyme is essential for the COVID-19 when it bonds to healthy tissue. But what happens is the anti-inflammatory compound, it's a protein compound, binds with this protease enzyme, and it effectively renders the virus useless. So the virus is just looking for something to bond with, and green tea, chocolate, and grape products, whatever, you can interpret grape products as you wish, but grape products will help to again render that virus useless. It can't bond with something else. So pretty cool stuff. Sorry, something just had a pop up here. So we don't provide it. I was able to get vaccinated through the city of San Antonio, and there have been a ton of resources available, but yeah, there have been some problems. It looks like a lot of you have been able to get it. But yeah, depending on your state, what level they rate you at, that's where a lot of the problems come in. I'm going to keep pushing through questions here. I can go for 6 more minutes. Do I incorporate MET levels into my plan of care? I haven't. No, I have. I'm not saying it's a bad thing. I just haven't done it. There are plenty. I don't know as far as free resources. I would Google MET levels if that's something that you wanted to do, but that's not something that I personally have done. I honestly haven't thought about MET levels since I was in PT school. What parameters should therapy follow when one is on one or multiple pressure? I'm not sure what you mean by multiple pressure. If you're talking about a CPAP or BiPAP, I'm sorry, I'm not 100% sure. I'm not 100% sure on that particular question. I'm sorry. Have you heard of younger patients running high with blood pressure? Not something that I've specifically seen, but it certainly would not surprise me, especially when you're starting to incorporate, when you're starting to look at the risk of stroke. COVID-19, decompensate quickly. We're starting at 60%, not going for 80. Is there research on this using low level of carvonin? Honestly, so many of our patients, if we were only allowing them to work at 60, they would just be sitting. So many of our patients are already over 60%, just sitting up in bed. So, you know, I'm using the full range, but I'm setting that, you know, that max, you know, that high end at the 80%. I'm allowing it to go there, but no, I don't want them exceeding it. Again, that goes back to so many, like their baseline is already over 60%. You guys are super involved. What are your thoughts about yoga breathing techniques to improve oxygen? Not a yogi person, not a yoga person. I am not a yogi, but I think those go right back. That's deep breathing. So I would think that's a good thing. Is it better to have SATs 90% on 1 to 2 liters and get a short, or add extra oxygen to get more distance? Good question. I think there's an argument to be made for both. I can't tell you that I think one is necessarily better than the other. I think there's an argument for both. It really depends on what your goal is for that patient. Me personally, and with most of our physicians, we're trying to, and even with most of our patients, they're all trying to get off of the oxygen as quickly as possible. What O2 sets trigger you sending the patient to the hospital? Good question. Honestly, with that, I mean, I would really be doing that in conjunction with the physician. I mean, if I walk into a patient's house and they're satting below 70 and the O2 isn't coming up and the patient is visibly in distress, I'm probably going to send that patient right to the hospital. However, if I walk in and I see somebody, you know, maybe you take that same person, they're not visibly in distress, and I'm able to do some deep breathing and get it up into a safe range, you know, I'm going to try to do some sort of an intervention first. But, you know, if it's below 90 as their baseline, I'm calling the physician, period, because that's our agency parameter. But as far as actually sending them to the hospital, I don't have like a specific number, but we're going to call the physician and then work in conjunction with the physician. Patients that are greater than 90, are you making them wear a mask? Do you always have a patient wear a mask? I'm always wearing an N95 mask, and I've also received both of my vaccinations. Ultimately, I encourage the patient to wear a mask, but I don't force them to, because in the home health setting, I'm in their home. But I certainly prefer it if they do. Please name any evidence on the acute IC, any evidence-based treatment studies. Ed, off the top of my head, I don't have them because this presentation doesn't include all of the references. If you email Summit Customer Service, though, I will get you my reference sheet from my longer course that probably has some stuff in there. If that helps. Diaphragmatic breathing works with pursed lip. Yes, absolutely. Yes. I like to use both of those. They work very well together. Please put up the right slide in relation to determining heart rate again. Yes, I can do that. Carvonin. It is slide, here you go, slide 14. been using the breather device and have good results to assist with diaphragmatic. Yeah, I mean, just right along with the inspirometer. Other ways to decrease inflammation in general. Ooh, I could find something. Again, if you email customer service, I probably have something. But as far as like just in general, I mean, non-pharmacologic. I mean, me personally, I'm into diet control. Where was the study about grapes, green tea, and chocolate? If you do a Google search on grapes, green tea, chocolate, COVID-19, it will pop up. Let me see if I can find it real quick. See, I'm doing the Google work for you. And then there, yeah, there's Science Daily. So it popped up 1, 2, 3, 4. It came up as the fifth one down. Chemical compounds in food can inhibit a key SARS from Science Daily. So grapes, green tea, chocolate, throw in Science Daily, throw in COVID, you'll find it. Very, very easy. And I think there's last question, recommend they purchase an inspiratory muscle trainer. When we're seeing them coming home from the hospital, most of them have one. If they don't, and I think they need it, then I would recommend it. The one thing that I recommend with everyone is the pulse oximeter. So that is it. 12:16. So I went a full 15 minutes over asking questions. I hope everyone found this informative. We went through the questions, comments, concerns, musing anecdotes, but that is it. So I thank you all. Have a great rest of your day.